Welcome to Lesson 6. In this section, we'll explore the essential laboratory tests that support the diagnosis and monitoring of cardiac amyloidosis, with a particular focus on biomarkers such as NT-proBNP and troponins. Let's begin by outlining the standard battery of lab investigations recommended for suspected cardiac amyloidosis: complete blood count, CBC, serum electrolytes, urea and creatinine, liver enzymes and bilirubin, urinalysis, NT-proBNP and troponin, serum protein electrophoresis, SPEP, and immunofixation, IFE, urine total protein, 24-hour urine protein electrophoresis, UPEP and immunofixation, and importantly, serum free light chain, SFLC assay. First, NT-proBNP and BNP, markers of myocardial stress. Natriuretic peptides, specifically BNP and NT-proBNP, are hormones secreted in response to ventricular wall stress. In the setting of diastolic dysfunction and restrictive cardiomyopathies, such as ATTR-CM, their levels become markedly elevated. This occurs because amyloid fibrils infiltrate the myocardium, increasing stiffness and impairing relaxation, leading to cardiomyocyte stress and elevated wall pressures. This stress activates proBNP synthesis, which is cleaved into BNP and the more stable NT-proBNP fragment. NT-proBNP is particularly useful due to its longer half-life and renal clearance, making it a sensitive marker of chronic ventricular stress. Figure 1 illustrates how progressive amyloid infiltration leads to cardiomyocyte stretch and biomarker release: NT-proBNP, BNP, and troponins. Diagnostic thresholds and interpretation. NT-proBNP greater than 3,000 picograms per milliliter typically correlates with significant LV hypertrophy and high filling pressures. BNP greater than 400 picograms per milliliter or NT-proBNP greater than 2,000 picograms per milliliter is often seen in NYHA class 3 or 4 heart failure. Interestingly, wild-type ATTR tends to present with higher NT-proBNP levels than hereditary ATTR, likely due to more severe diastolic dysfunction. These levels are not only diagnostic, but also prognostic. Higher concentrations predict worse outcomes and correlate with greater amyloid burden. However, NT-proBNP isn't specific. It can be elevated in other conditions like hypertrophic cardiomyopathy or heart failure with preserved ejection fraction. Also, renal dysfunction may falsely raise NT-proBNP levels due to reduced clearance. Therefore, context and correlation with imaging are key. Now let's turn to troponins, specifically TNT and TNI. These are structural proteins that leak into circulation following myocyte injury, and while they're classically used to detect infarction, in ATTR-CM, their elevation reflects chronic subclinical injury. Why are troponins elevated in a TTR? Amyloid fibrils cause direct myocyte infiltration and injury. Amyloid-laden coronary microvasculature results in subendocardial ischemia, even without coronary artery disease. Increased LV wall thickness adds to subendocardial hypoperfusion, worsening the injury. The myocardial injury is multifactorial. Mechanical stress, ischemia, and direct toxicity all play a role. Clinical significance. Persistent troponin elevation greater than 0.05 nanograms per milliliter is associated with increased mortality and worse functional status. These markers are particularly useful for monitoring therapy such as tafamidis, as trends in troponin can indicate treatment response. Unlike in acute coronary syndromes, where we see transient spikes, troponins in amyloidosis remain chronically elevated, reflecting ongoing injury rather than episodic ischemia. Clinical integration of biomarkers. In practice, NT-proBNP and troponins are integrated alongside imaging findings and genetic testing. They help stage disease, estimate prognosis, and guide treatment strategies. This figure illustrates how biomarkers complement imaging, biopsy, and genetic studies in managing ATTR amyloidosis. Interestingly, NT-proBNP is typically lower in ATTR compared to AL amyloidosis, likely due to lower cytotoxicity of TTR amyloid fibrils. This makes these values helpful in distinguishing subtypes when considered in context. Screening in asymptomatic mutation carriers. For individuals with TTR mutations, it's advised to begin biomarker screening 10 years before expected symptom onset. We will discover that further in Module 5. Elevated NT-proBNP or troponins, even in the absence of symptoms, should prompt early imaging, including bone scintigraphy. To summarize, NT-proBNP reflects myocardial stress, while troponins reflect injury. Both are elevated early, remain elevated chronically, and provide powerful diagnostic and prognostic insights. Used in combination with imaging, they significantly enhance diagnostic accuracy and guide disease monitoring in a TTR-CM. Let's move forward to our next module, where we'll explore the role of nuclear imaging and monoclonal protein screening in the diagnosis of cardiac amyloidosis.